Hi everyone, welcome to today's Preferences for Everyday Living PELI FAQs webinar. My name is Kendall Lesser and I am the project manager for the newly funded grant entitled Incorporating Preferences for Everyday Living into Ohio's Nursing Homes to Improve Resident Care. I recently earned my doctorate in public health from The Ohio State University and I'm very excited to be a part of the PELI team. Before we get started with the presentation, I have a few housekeeping items to go over with you. I ask that for those of you seeking Ohio Social Work CEUs, which I believe can be transferred to nursing CEUs, to please take a moment and click on the link under the chat box and complete the form. That link starts out as https://Miami, Ohio, Qualtrics. So please take a moment and complete that form. In order to issue CEU credits, we must have a record of you signing into and out of our webinar. At the very end of the webinar, you will be asked to complete a webinar evaluation and enter the time that you exited the webinar. Please expect to receive a PDF of your CEU certificate via email within the next 2 weeks. Today, we are going to be discussing the PELI-NH and tips for getting started interviewing residents with the PELI. We will also review available resources and answer your questions at the end of our presentation. If you have questions throughout the webinar, please type them into the Q&A chat box and we will answer your questions at the end of the presentation. On the screen, you see an example of where you can type your questions. For those of you just joining, please take a moment and click on the link in the chat section if you're interested in completing your CEU credits for social work or nursing. Now I would like to introduce our speakers for today's webinar. Dr. Kimberly Van Haitsma is an associate professor of nursing at Penn State University, as well as the director of the Program for Person-Centered Living Systems of Care and a senior research scientist at the Polisher Research Institute at the Abramson Center for Jewish Life. Dr. Van Haitsma's research focuses on seeking to understand the impact of contextual factors such as physical environment, culture of care, staff interactions, interdisciplinary team processes, and psychotherapeutic approaches on quality of life and quality of care delivery for frail seniors receiving services in the long-term care setting. Our next presenter is Dr. Katherine Abbott. Dr. Abbott is the Robert H. and Nancy J. Blaney Assistant Professor of Gerontology and a Scripps Gerontology Center Research Fellow at Miami University. Dr. Abbott's research and teaching focuses on preference-based, person-centered care with a special emphasis on persons with dementia. Doctors Van Haitsma and Abbott have co-authored over a dozen peer-reviewed articles related to the PELI. We also have two guests from the Ohio Department of Medicaid joining us today. Amy Hogan is the Policy Manager, and Cheryl Guyman is the Nursing Facility Policy Administrator at the Ohio Department of Medicaid. Amy and Cheryl will be kicking off the webinar and providing some clarification about the PELI Quality Indicator Payment Process and person-centered care goals for Ohio's nursing homes. I will now turn it over to Amy and Cheryl.
Can everyone hear me?
We can hear you, Cheryl. Thank you.
Oh, great. Thank you very much. Good afternoon, and thank you, everyone, for attending. I wanted to talk just briefly about two issues. One is that regarding the PELI, there is Ohio statute that requires use of the PELI, but I want to talk more about the fact what our goal is as far as person-centered care. The first thing, we use the PELI when we determine the Medicaid quality payment rate for SNFs. There's 5 criteria, and one of the criteria is that the facility uses the PELI for all of its residents. And this was effective July the 1st, 2016, and how we measured this was how people responded on their cost report submitted to Ohio Department of Medicaid. And what we asked was the nursing facility utilize the nursing home version of the Preferences for Everyday Living inventory for all of its residents. And the box was either checked yes or no? I know that there's been some concerns from people about, well, it says all of the residents and we use this tool and how many questions do we have to answer? And really, our goal is to focus people on person-centered care. And we really don't believe that people can implement all of the PELI for all of the residents. However, if you're completing an MDS for your residents, which you are doing, you're already incorporating some of the components of the PELI. And those of you who are part of this project, I know that the instructions will be to help you by selecting a few things at first that you can do for your residents. And I want to give an example. I see surveys all the time, and yesterday I saw a survey where a resident, the facility was cited because a resident wanted his shower in the morning, and he was told no over and over, that he had to have it at night, and he didn't want it at night. And it seems so small. However, if you can take one item, 2 items to start with, and implement those for your residents, you'll have the outcome, I believe, that you're going to be looking for. Again, this measure for the cost report is self-reported. Medicaid has no intention of going in and actually auditing for this particular quality indicator. Next slide, please. Again, CMS, Ohio Department of Medicaid, Ohio Department of Health, the Department of Aging, we all support the goal of providers focusing their attention on person-centered care. And again, we look at tag F240, which talks about quality of life, and there's many other F tags that are related to that. So it's a critical tag. Once you are cited for one in this group, then the surveyors are instructed to look at other areas. Now, the Ohio Revised Code quality statute in the previous slide is not related to the survey process. But what I mean by that is ODH does not come in and look at, did you complete a document for each of your residents? Rather than doing that, the surveyors follow the CMS guidelines, and they look to see if you're indeed providing person-centered care. And I know that you're all very familiar with that. And again, it's how are you meeting the needs of your residents on an individualized basis? And that's what all of our goal is here. Next slide. Oh, I'm sorry. Okay, so the surveyors, again, are looking to see, we all know they talk with the residents, the staff, the families, they look at resident council minutes, they want to see that you're resolving issues, that people are involved in their care planning. So it's not that they're going to survey whether or not you fill this document out or the MDS, because that's just part of the process as the surveyors are viewing whether you're in compliance with federal and state regulations. One of the things, though, that is helpful is that you can point out to the surveyors that you have gone above and beyond and are trying to meet the person-centered care initiative. And so if you're part of a project like this, it looks very good to show how, it's just a good example of how you're really trying to meet the needs of your residents on a person-centered level. And what I've encouraged people to do, since the statute and our rule are very vague about this, I encourage, and we at Medicaid encourage facilities to come up with their own facility-specific policy for how they're going to implement PELI and for assessing and implementing preference-based care that makes sense and are tailored to the needs of their community. And we all know everybody has a different population, and so what we encourage people to do is select the first areas that will make sense for your residents. For example, you could have a facility where you have a lot of behavior problems and smoking. So maybe you're going to implement some things to address that meets the needs of the resident but is consistent with your facility goals. Or you can have a population that's very skilled and subacute, and these individuals may have completely different preferences as far as maybe they want to eat breakfast later on, and so you can make a continental breakfast available for for those residents who desire that. So again, it's looking at your facility and coming up with the simple things to meet the needs of your residents. And I know that's not as easy as it sounds, but we're really excited about this project because we really want to put some tools in your hands to be successful at attaining person-centered care. Thank you, and I'll turn it over.
Wonderful. Thank you so much, Cheryl. And my name is Katie Abbott, and I want to again welcome you to our initial and first inaugural webinar that we're doing as part of this project, and we're very grateful that both Cheryl Guyman and Amy Hogan could join us for this important clarifying information. And it looks like the Q&A might not be working for people, so please enter any questions that you have into the chat box. We can see that chat box. And so please do that, and we will answer your questions at the end of the webinar. And so what I wanted to do at this point is turn it over to Kimberly Van Haitsma to start us off. I need to unmute her, and we will continue. Kimberly?
Very, very good. Thank you, Katie. As Katie said, we're very excited to be a part of this kickoff webinar and to really start what we hope is several years of being a resource and working in partnership with facilities across Ohio. And just a little word as us as a group, as a team, that the recommendations that we're going to be sharing with you today and that we're going to be working with you on for the next ongoing webinars are based upon our experience and expertise of over 15 years of working with the PELI nursing home in terms of its development, testing, and implementation. So we're really passionate about this topic, and we've been really passionate about the idea of using preferences as a way of a beginning point of delivering person-centered care. So our goal here is to assist providers in the practice of preference-based person-centered care. And we're going to be talking about the development of action plans, procedures and policies that Cheryl and Amy just mentioned, and also formalizing how those preferences are assessed and then utilizing that assessment information to actually enhance care and change how care is delivered. As we all know, the industry is shifting toward a person-centered philosophy of care. I think it's been very exciting to watch this pivot toward, away from a medical model toward this holistic person-centered philosophy. And again, the core of this movement really is focused as a beginning point around understanding each individual that we serve in terms of what their preferences, their goals, their values might be, and then seeking to honor those preferences, goals, and values throughout the care delivery process. And I think we can all agree that all of us would have and share that goal, but of course it's not as easy as it sounds. And so the focus here is going to be on helping to uncover those techniques that will objectively measure person-centered care for care planning as well as QI purposes. And that's really our hope, to be able to share with you and also to learn from you about what some of the best practices are out there already that we may be able to learn together as we move forward. But we certainly have a lot of thoughts and advice in terms of our own experience as a team that we're eager to share with you. So just a little bit of background on the PELI. The PELI itself was originally tested in home care with 550 older adults who were receiving home health services. And then we really went from there to revising it for its use specifically in a nursing home population. And to do that, we enlisted the help of older adults themselves in helping us to guide the wording of those preferences, making sure that the content was specific to nursing home settings. And that resulted in these two versions that you see here, one called the PELI Full and one called the PELI Mid-Level. And the idea here is that the difference between the two is that the PELI Mid-Level asks the big scoping questions in terms of preferences. So an overall preference for music, for example, would be asked in the mid-level, and then the PELI Full would go into that musical preference more deeply and ask specifics about what that musical preference may entail for that given individual. So the staff can then use the answers to this questionnaire to learn more about the resident preferences, and then our work has also included studies on how to incorporate resident preferences into care planning, as well as quality improvement efforts. So we do give full permission granted to all healthcare providers for the use of this tool in their practice, and we hope that we will see all of you take this tool and use it.
Wonderful. Thank you so much, Kimberly. And so this is Katie again, and I'm going to take it from here and start into one of the documents that we have prepared for you. And the first thing is how do we assess preferences using the PELI? And so I know many of you are probably very familiar with the PELI, but if not, it's a 72-item inventory that assesses the importance of a range of preference domains, and it's on a 4-point scale where we ask participants to rate how important something is to you from very important to not important at all. And these are an example of the 5 domains, the broad domains that questions are embedded within. Here is an example of what the full PELI looks like that Kimberly mentioned. So you can see on the left, question 43, how important is it to do things with groups of people? Now you will also recognize that this is one of the MDS items. And so what someone will answer is they'll say, if it's very important, somewhat important, important but can't do, then you could move to the right and ask those probing questions to get some more nuanced information that can help you in the care planning process. If it's not very important or not important at all, then we suggest that you move on to the next question. And so then you can see another question is, how important is it to you to meet new people? And the inventory goes on like this as you go. Anything you'd like to add, Kimberly, on this slide?
I did that very thoroughly. Thank you.
Okay. All right. And so as Kimberly mentioned, we have a couple of versions for you. The versions and the tip sheets we're going to go over with you today are all available at www.preferencebasedliving.com. And you can see the website link at the bottom of the slide. And we will also give you we'll give you the link at the end of the presentation as well. So both versions of the PELI as well as the tip sheets we're going to review today are on this website right now, and you can download as PDFs. And this is what the first tip sheet looks like. And this tip sheet starts out from the very beginning of your process. How do you get started assessing preferences? And again, all of our recommendations are coming from many, many conversations that we've had with organizations and clarifying, does this work? Does this work? And so a lot of these are suggestions that we can recommend, but obviously we understand that you'll need to take what works for your organization and turn it into something that's unique to your own culture. So the first thing we recommend is to form a core team to kick off your initial efforts. We recognize that if you have one person as the champion, if that person leaves the organization, gets promoted into a new position, the whole effort sort of falls apart. So that's why we recommend a team of people so that your efforts are more sustainable over time. There's many different ways to find out who these people could be. But the bottom line is they need to be passionate about honoring resident preferences and their choices, and have some leadership qualities. Be able to work closely with employees who will conduct the resident interviews, We suggest that this core team actually start out doing some of the interviews and then train other individuals to do the interviews, and we'll get to more of that in a little bit later during our webinar. It would be helpful if someone on the team knows how to develop and use a tracking system, such as an Excel spreadsheet, and then also be able to reflect on the process and identify areas of weakness and then seek continuing education opportunities like the ones we'll be offering. The next step that we recommend is to select interview questions and create your interview form. And in terms of the items from the PELI, we have a couple again. These are things that have worked for other organizations we wanted to share with you. Some organizations select 10 to 15 items from the PELI and ask them in a pilot phase. And this is when you're starting to focus on quality improvement. We feel that it's more feasible to focus on a smaller subset of items than to try and tackle all 72 items. That's a little overwhelming. So one of our favorite taglines is baby steps to world domination. And so one of the first steps is just pick the core items that matter to your organization, maybe that speak to your mission or speak to the individuals that are part of your team. Another idea is to divide up the 72 items by departments and ask questions by discipline. So you have recreation therapy asking the 28 recreation and leisure items, for example. And we can share more information with you about that if you're interested. You could also focus on the 16 MDS items in Section F that Cheryl mentioned earlier. And you could partner those items with the probing questions that are available through the full PELI to, again, get that nuanced information that can be used in care planning. One thing that we want to point out in the MDS Section F, if someone says that an activity is important but I can't do it, the PELI full form, first there's two things. One, that triggers, CMS will ask that you care plan around that item if someone says that it's important but they can't do it. And again, the probing questions from the PELI full help you do that, to sort of look into this and dig into it a little bit more, to devise ways to fulfill the preference of that individual. Okay, so next step, step 3. You want to be able to select and train your interviewers. We have seen organizations use activity professionals, nursing assistants, social services staff, and volunteers, and sometimes even family members have been willing to interview their older, their relative and hand the form in to the organization. And so these are all opportunities, but we want to make sure that if you're using volunteers, that you give them some training, especially if they're going to be interacting with people with dementia. And so we're going to be reviewing some of those tips in a minute, so hang on. And then the final step in terms, or not the final, but the next step in terms of how to get started is to use the assessment information from the PELI to inform your care planning meetings. And so again, it's discovering what each resident's unique interests and passions are, and then discussing as a team, how can we think creatively to meet this preference of an individual. All right, and now what I'm going to do is turn it over to Kimberly to start talking about our second tip sheet, which is about interviewing tips. Kimberly, take it away.
All right, thank you, Katie. So once you've got your team selected and they're underway, as Katie mentioned, now you have the job of figuring out how to begin collecting the information. And two things to really keep in mind as you begin this process, and that is that the last thing I think we want to see happen is that this, in a person-centered approach, we try to avoid making things become tasks, yet another task that you have to do. And this is certainly true when it comes to the PELI, that the overarching concept is that these interviews provide an opportunity to get to know the resident to build insight into what's important and meaningful to that resident, to build a relationship, a deeper relationship with that person, and to engender respect and trust with that individual. So again, that's sort of the overall viewpoint in terms of the starting reason why we're doing this. We're really doing this for the purposes of gaining knowledge, enhancing relationships, and building that respect and trust. And so the very first thing is to keep in mind that if you are doing all 72 items, that to do it in one session is really challenging. And not only can it reduce the quality of the data that you receive, but it also could be a bit off-putting to the resident if they become tired or fatigued as they're going along, to sort of push on, in the spirit of finishing the task. Is again something that is antithetical to what we're hoping to accomplish. So that's the idea of spreading these over more than one session. There will be some residents, of course, who can do it all in one setting and sitting, and will actually, the majority of the residents really love the opportunity to talk about what's meaningful and important to their daily lives. So again, just keep in mind for those folks who may be fatigued and may not be able to complete all 72 items, and plan for that as you're going forward. So reviewing all the instructions, there are some tips and instructions that you'll find on the PELI itself to review those prior to speaking with the resident, so that you as the interviewer are fully prepared, or whoever you select as a part of your team who is doing the assessment is fully prepared. And then the really important tip here is to stress that you're seeking an honest answer about what the resident would prefer, and to avoid thoughts about putting suggested answers into the person's mouth that you're interviewing. So, we're really interested in their honest point of view about what it is they prefer, and whether or not they feel like this is something that they are currently getting at the moment or not. Because oftentimes, as Katie already pointed out, people will say, well, that I do prefer that, but I can't do that right now. And that those are really the responses that we want to follow up on and say, yes, we're very interested in seeing if there is a way that we can address that preference. And again, understanding that sometimes we're not going to be able to address a preference for a variety of reasons, but that you're sincerely seeking to address that preference is really the stance that we want to take. So again, reviewing with whoever your interviewers are in your organization, this purpose that I just went over, that again, this is not a task, but an opportunity to learn more about the resident, to build that relationship, and to enhance the organization's capacity to deliver person-centered care. You also want to review the scheduling, how the schedule of the assessment is actually going to be rolled out, making sure you have the materials on hand, and our tip sheets would be a good starting point in training the interviewers. And as Katie has already mentioned, we recommend that the champion would actually start the interview process and be observed by a trainee, and then the trainee could conduct the interview while the champion observes. And if staff time is limited, which it often is, and many of the organizations that we've worked with have considered training volunteers to conduct some of the PELI interviews as well. And it's important to think about the environmental conditions and the setting in which the interview occurs. So selecting a comfortable place for the interview to happen, and that it's in a private setting. And again, these are all tips that you as providers would be more than familiar with in terms of the interview process for the MDS in general. they all apply here as well. So these tips that you can see the resident's face, making sure that you're minimizing glare of any direct light sources away from the resident's face, making sure that the person can hear you, that they have their hearing aid in or other communication device that they have on hand, the use of a hearing amplifier, or making sure that the ambient noise in the environment is reduced, so TVs are off, that there's not a radio blaring, those types of things that would interfere with the resident's ability to hear you. And then printing and handing the last page of the PELI to the resident, which is the list of the response options printed in large font size, is also very important to help orient the resident to the response set that you're looking for the resident to use. So as I said, oftentimes the resident will say they can no longer do a particular preference, and here's a couple of ideas around that. So again, to say to the individual something like, I want to know about every activity that would be important to you if you could do it with assistance or support. And oftentimes people will say that they can't do it because of some functional impairment. And again, that's where we get creative as providers to try to tailor that particular preference fulfillment in a way that is tailored to the strengths, remaining strengths and remaining capabilities of that resident. If the person says that they can no longer do a particular preference, again, you would select important but can't do or no choice, and proceed accordingly, as Katie has already mentioned. I already mentioned about not putting words in the mouth of the resident, and again here, I have an example of a person who was being trained to do this preference assessment, and they were very shocked when the person that they were doing role plays with answered the religious practices and preferences question and saying, no, that's not important to me at all. And so the person who was doing the interviewing was saying, oh my goodness, really? Are you sure you don't have any religious preferences? And so again, that type of thing is we want to avoid, because we're really interested in understanding from the resident what their perspective is and not to interject our own. Sometimes this happens with family members as well, in terms of the family member interjecting what their preference is, whether the resident's preferences might be. So again, we're really seeking to get that resident point of view. Really important to give the person time to collect their thoughts and think about this. Oftentimes we find that people are not used to thinking about what they prefer. And so this idea that when you're asked for the first time about what your preferences are, we often don't know right at the top, off the top of our head. And sometimes it takes a little bit of thought and gathering one's thinking about what really is an important preference for us. So the offering a prompt such as, is there anything else you'd like to add, or can you say a little bit more about that, gives people time to sort of expand on some of their thoughts as you're going through the assessment process. Next. And then finally, to just remember to thank the resident or the family member or friend at the end of each interview session, and let them know that how the information will be used, and that again, the organization has a real commitment to helping to use these preferences to plan their care and their daily activities, and that again, that you appreciate that the resident has provided you with a meaningful opportunity to learn more about them, to personalize their care, and to help the organization focus their time and resources in a way that will help him or her feel happy, cared for, and comfortable with daily life. And that's really the goal of the interview and the goal of the organization in their care for that individual. Okay, so those are the first two tip sheets that we have, and as we've said, they are available on the Preference-Based Living website. But now is our opportunity to really hear from all of you in terms of some of your facilitators, what has been going well in terms of assessing and implementing the PELI, or some of the barriers that you've been experiencing in the process of doing that.
Great. Thank you, Kimberly. And I see some questions coming in. And what I'd like to do before we start to answer all those questions is to give you a little bit of information, and then we'll spend the rest of our time on questions. So first, in case maybe you think of a question after the webinar, which I often do, it often takes me a little bit to process information, please just email us or call us. And we will also make this webinar available. Give us a few days to close caption it, and then we will upload it and send you a follow-up email to let you know that it's available so you can access this webinar in the future. But don't hesitate to reach out and send us your questions. We're going to have our next webinar next month on Wednesday, October 26th, and I'm thinking it's at the same time. It's not 1 to 2. I think we're going to do it from 2 to 3 like we did today. But we will send you an email about that as well. And you can also register via this link that's on the screen. Essentially, the bottom line is that we're seeking to create a partnership with all of the providers in the state. We want to learn and help share the successes and stumbles that people are experiencing with the PELI. And to that end, we'd love to embark on a listening tour. We would love to be invited to your facility. We're interested in learning how you have implemented the PELI, what your barriers and facilitators are to doing the PELI, and to sort of taking that assessment information and turning it into a meaningful care plan. So please reach out to us. You can contact Kendall Lesser or myself to schedule a time. We're willing to travel wherever in the state. So please take us up on that offer. We'd really love to understand how people are doing this really important but difficult work. As I mentioned earlier, you can find all of these resources on preferencebasedliving.com, as well as please sign up for our newsletter so that we'll send out a monthly newsletter, and we'll notify you of webinars and of future tip sheets that we develop. We're also developing a Dear PELI section of our newsletter where we get questions coming in from people, often anonymously, and we'd like to be able to respond to those in the newsletter. And so please sign up for our newsletter. And then what I'd like to do at this point is to open it up for questions. For those of you who have them, I see that we've got some questions coming in. So Kendall, can you see the questions as well, or would you like me to read them?
No, I can see them, and I will go ahead and read them.
Oh, great. Thank you.
Yep. So the first question we have is, how many questions at the minimum do we need to ask? Is it 72? I was recently with a company and said it was okay asking questions from Section S of the MDS. So just some clarification on how many questions these nursing homes need to answer in order to fulfill the requirement.
Great. So what I'd like to do is go back to the slide, because so the answer, one of our favorite sayings is, it depends. So if you're asking about the quality point, and this is something that I might turn it over and to have Cheryl also clarify. If you're asking how many questions at the minimum you have to ask to receive your quality point, my understanding from Cheryl is that if you are asking the MDS items and implementing that information into your care plans, you can self-select that you are doing this work. Cheryl, do you have any additional comments for that?
That is correct. And again, as has been mentioned all along, the goal of, I believe, everybody from the state perspective and from your perspective is to focus small and do the small things right and expand your program. You know, it would be wonderful to get one question for all of the residents, truly functional. If everyone could have a shower when they wanted to, that would be great, and then sustain it. So it's all about really focus on implementing a program, small, and focus on sustainability. And once you put things in place for sustainability, then focus on something else. So again, baby steps get you to where you want to be.
Great. And Kimberly, would you like to add anything?
Yeah, again, I just want to amplify what Cheryl said, which is I think that as you build capacity, and starting with the MDS is certainly a good place to begin. I think that the in-depth items from the PELI that relate to those 16 items on the MDS do help providers in that process of beginning to implement, develop those methods and structures within their organization to sustain that change in areas that the organization selects as important. And for example, one interesting place to begin is to take a look at the MDS items and see which ones are the most frequently endorsed as important or important but can't do among your whole population in your facility. And whatever those items may be are a really good place to start that whole process of thinking about implementation and quality improvement to address those preferences first. So that is a suggestion that other facilities have used and find works really well for them. And then once you get those structures and processes in place, it's an easier lift to start looking beyond and say, okay, so what other kind of preferences are important to our residents? And then you can expand out to looking within those other 72 items, which ones may be the next step for you to take a look at. And as quality improvement is indeed a journey, and you are never done. So the fulfillment of preferences is indeed a journey, and is indeed a person-centered care initiative that will occupy all of us for many years to come. So I think the question, though, is well asked. You know, where do you begin? And starting with those MDS items and really digging into those items is certainly one very good option.
All right, thank you, Kimberly. So we had another question that popped in, and it was just asking, how do you get your CEU credit hours? And I'm going to go over that at the very end. And unfortunately, if you needed to be here for the duration of the webinar to receive those credit hours, and you needed to click on a link to log in and get those credits at the very beginning. So there is a link in the chat box where you can sign in, but you also need to be there. So if you're going to get 1 hour for this, you need to show that you signed in and received your 1 hour. So I will go over the instructions at the very end on how to sign out of the webinar. But another question that came in is, why does this have to be done to residents that are only here short-term? I can see doing it with long-term residents. So just if you can clarify the difference between short and long-term residents in regards to the PELI.
Thanks, Kendall. And it's, again, a great question. We recommend that you start with your long-term residents. It's, again, for all the reasons that you probably have embedded in that question, this is a relationship-building activity, and this is with relationships you intend to have for quite some time. Your short-term residents are not going to, they're more transitory. They're not going to be there for as long. If you have not only a skilled nursing facility but a home health care agency, what we recommend is that if it's possible to ask the PELI items while they're in short-term stay, that's a document that you could hand off to your home care organization. So Cheryl, let me see if you'd like to add anything.
Well, the one thing that I would say, though, is I see I agree with you completely on that end, but I do see some areas where with your short-term residents that I would really ask people to focus on. And the number one that I still see on surveys is pain management. So when someone comes in the facility, getting with them and making sure that you're meeting their needs regarding pain. And then some of the other areas, for example, the short-term people usually are getting therapy, and many of them do have pain associated with maybe they've had a surgery or a fracture. And so, again, focusing on pain with them is really, I'd say, one of the biggest areas to be concerned about. The other thing is, again, you need to start small and grow, but some of the things that you could look at later on is the continental breakfast idea. Some of those ideas that your short-term people, it might better fit into their typical living arrangement at home. So again, start where you feel you really need to as a facility, and then just always keep in mind that you can improve.
Fantastic. Kimberly, anything you'd like to add?
Yeah, again, I think I'll just amplify on what both Cheryl and Katie were saying, and that is, when you're looking in the short-term rehab environment, the use of the PELI items has a slightly different purpose. In long-term care, it's really clear, as we talked about, that we're in this to develop this meaningful living and build relationships with that individual. But, in short-term rehab, of course, people go to many different places following discharge, but discharge is the goal, and hopefully a discharge with an excellent transition as a part of it. So when we think about preferences in the transitional world, what research is really clearly showing is that when we think about our discharge plans and develop these rehab plans based on people's preferences and take those into account as we're designing those discharge plans and goals, we find that people have better adherence to the recommended approaches that are used, that people have a much better transitional experience. And so really here in this space, we're really talking about preferences serving a role in crafting the plan of care that results in better adherence, better transitions, keeping that person in whatever environment that they're going to in a way that is very productive for them and very meaningful for them. So I just wanted to emphasize the fact that this is a way of looking at preference-based care that is really fits the needs of that short-term population and is a much different way of kind of thinking about how we use preferences.
Great.
All right.
Thanks. Sorry.
Sorry, Katie. We have a couple more questions on the main chat box, and that is, how often do we have to do the PELI annually, and how often do you need to do it on long-term residents? Do you have to do it annually? Just how often do you need to do it?
That's a great question. Please keep the questions coming. These are great. So we have actually done some research on the stability and consistency of resident preferences, and we will have a future tip sheet and webinar about this very piece. What we would recommend, we say to you, is what makes sense first for your organization. We have looked at data based on a 3-month time point. So we asked 255 residents their preferences at time 1, and then we went back 3 months later and asked them the same. And we saw a lot of stability in preferences. However, there were some interesting nuances. Kimberly, would you like to talk about sort of the interesting nuance that we found and the consistency of our preferences of the residents?
Yeah, so I think one of the interesting findings in this is that residents whose emotional and social well-being is compromised in some way are much more likely to change their mind about what preferences are important to them. And so when we think about this, we're really thinking about, again, through MDS assessment, we learn whether somebody has depressive symptoms, whether they are showing poor psychosocial well-being and those items. And those people who are showing a change in those responses, so in other words, if they are becoming more depressed or they're becoming, their psychosocial quality of life is decreasing, our research seems to suggest that they're going to be also showing changes in their preferences, and we may want to go back and target those individuals with a more frequent preference interview. But let me also say that I think, just backing up to what is done in from the MDS perspective is that, you as providers are all doing the MDS annually. And so I think, looking at these questions at a minimum on an annual basis would probably be a good best practice.
Great, thanks. And we also see that for those individuals who have more depression and anxiety, preferences are more important to them. They have more strongly held preferences. And so again, we're going to follow up and do a future webinar completely on this topic because you're right, this is a great question. We've had a couple of questions come to me that I don't think everybody else can see that I want to ask. So this one, am I correct in thinking that we can use our own form to expand on MDS questions preferences, or do we have to take the actual PELI questions word for word? I'm not sure what use our own form means. Kimberly, why don't you talk about the cognitive interviewing that went into the development of the PELI and why, and sort of the science behind it?
Yeah, thank you. So the technique that Katie is talking about, cognitive interviewing, is a technique that is designed to really go in a very in-depth way and to understand from the whatever your target is for an assessment tool. And of course, in this case, we were targeting nursing home residents. We wanted to understand from their perspective, with their voice, how they were interpreting questions. And they really served as the guide to the exact wording of how these preferences were asked. And so in fact, it took us 3 years of doing the interviewing with these individuals to derive the exact wording that you see in the PELI. So they were not casually chosen. And were deliberately chosen and crafted from the perspective of the resident. So I would say that, if you have some additional items that you would like to add in, additional preferences, and again, we in no way say that the 72 items on the PELI are completely comprehensive and inclusive of every preference there ever was. We certainly don't mean to suggest that. So if there were other things, other preferences that you see missing, that you would like to add in, I would say that that is perfectly acceptable to do. But changing the wording, just keep in mind that you're changing the wording of the perspective of over 350 nursing home residents strong that completed this PELI and helped us to craft the exact wording of that question.
Fantastic, thank you. And then I think we have 2 more questions that we might be able to get through in the next couple of minutes here. Let's see, is there a certain amount of time from the resident's admission that we need to have the PELI completed? And so again, I'll say that you need to think about what makes sense for your organization. Our recommendation is that the sooner you're able to assess a resident's preferences, the sooner you can start to build a relationship, get to know this person, and understand how you can make the care more person-centered. It also might take a week or 2 for somebody to sort of get into the routine or the groove of their life, but you don't want them to sort of say, oh, well, this is what's accepted. I guess I can't ask for what I prefer. So by starting the conversation as soon as somebody moves in, at least setting the stage to say, we're really interested in understanding what your preferences are. If they're cognitively capable, you could share a copy of the PELI and say, we're going to come back and ask you some of these questions if they're not able to talk right there. Kimberly, what would you like to add?
No, I think that's a really good summation. I mean, I think, again, we don't want to say that you would ever overrule your clinical judgment in this regard. Some people have a very hard time with the adjustment process coming in and may not be, they may be overwhelmed within the first few days. And so in that case, you would want to hold off. And other people would be, delighted to participate in an interview like that. So again, using your clinical judgment to make that decision is really important.
Okay, and then the last question that we'll take before we sign off. I can see the pain management. However, you don't do the PELI till they hit 35 days, correct, on short-term residents? So again, I think we sort of covered this a little bit in terms of you first start with your clinical judgment. And if someone is there short-term and maybe transfers into long-term, we would recommend that you start to lay the groundwork for understanding someone's preferences sooner rather than later. And so at this point, we'll stop with questions. If you have further questions, please don't hesitate to send us emails. We absolutely would love to respond to you either through phone or through a newsletter. And then I want to turn it over to Kendall, who's going to explain the CEU process.
All right, thanks, Katie. So for those of you seeking CEU credits, I need you to click on the link in the chat box and sign out of the webinar and complete a webinar evaluation form. And as a reminder, you will receive your certificate for your CEUs via email within the next couple of weeks. Scripps Gerontology Center at Miami University is the institution that honors these CEU credit hours, and the person who does it is out on vacation, so just be patient with us, but we will get you your certificates within the next couple of weeks. And for everyone else, I just ask that you can click on that link as well, even if you do not want CEU credit hours, and just complete the webinar evaluation. And by you completing the webinar evaluation, it really allows us to take your feedback so that we can improve our future webinars. So again, the link to get your CEU credits as well as the link for the webinar evaluation, they are the same link and they are in the chat box now. So I just ask that you click on that and complete it. And for those seeking CEU hours, just be patient with us and you will receive them within the next couple of weeks. Thank you so much for your time today. We really appreciate you taking an hour to spend with us to learn about the PELI and so how you can honor the preferences of your nursing home residents. So thank you again for your time.